Hello my dear students. Today we are going to talk about eczema, that is also called atopic dermatitis. So what is eczema or atopic dermatitis? Eczema is a common chronic inflammatory skin disorder in children that is characterized by dry, intensely itchy skin and recurring erythematous rashes. It affects quality of life by causing sleep disturbances, psychological effects and increasing the risk of secondary infections because the barrier function of the skin is lost. So let's see some pictures of atopic dermatitis or eczema. See, this is a picture of atopic dermatitis and it happens in the knee. Now let's come to the pathophysiology. Okay, let's see the epidemiology. How many people are affected in these diseases? It affects about 15 to 20% of children in the UK. Typically begins in infancy and in the first 6 months of the infancy mainly. More common in children with a family history of atopic conditions. Like atopic conditions are like asthma, allergic rhinitis or eczema. And the course of the disease is variable. Some children outgrow it by adolescence while others have lifelong symptoms. And now about the pathophysiology of the disease. There is multifactorial causes including the genetics, the skin barrier dysfunction, the immune dysregulation and also the environmental triggers. Let's come one by one. In about the genetics, there is filaggrin gene mutations, that is loss of function mutations disrupt the skin barrier, that is loss of function mutations disrupt the skin barrier, increases transepidermal water loss, making the skin vulnerable to allergens, irritants and microbes. So there is the skin barrier function is lost. And another thing is skin barrier dysfunction. There is deficiency in lipids and filaggrin mutations weakens the skin barrier. So the water loss is increased. So the skin is now dry and dehydrated. There is cycle of inflammation happens. So more itching, redness and also the skin damages. There is also immune dysregulation. There is T helper 2, Th2 skewed response with increased IL-4, interleukin 4, interleukin 5 and IL-13 promotes IgE production. Increased eosinophilic inflammation. Where there is allergic manifestation, we know that IgE is increased, IgE production is increased, so there is eosinophilic inflammation. And now lastly the environmental triggers. There is some allergens like dust mites, pet dander, irritants like soaps, detergents and also the microbial factors. Staphylococcus aureus worsen the symptoms. Actually in the atopic dermatitis there is a chance of secondary bacterial infection with Staphylococcus aureus. Now coming to the clinical symptoms, clinical features of the disease. In infants, that is less than or equal to 2 years, it most commonly affects the face, scalp and trunk, sparing the diaper area. The diaper rash is distinguished from this. And the key features are intense pruritis, erythema, xerosis, that is dryness. In young children, that is 2 to 12 years, it commonly affects extensor surface, elbows, knees, extensor surface, elbows, knees. It is most common in this age group and can spread to the other areas. The key features are same like dry, itchy plaques, potential for excoriation. Other older children and adolescents, that is more than or equal to 12 years, it also affects flexural areas, that is antecubital and popliteal fossa, neck, periocular region. The key features include lichenification, chronic lesions, possible secondary infections. The chronic features of this disease includes lichenification, excoriation, secondary infections with Staphylococcus aureus or herpes simplex virus HSV. And the clinical features include thickened skin, persistent pruritus, recurrent flares. Associated symptoms with this disease, sleep disturbances due to itchiness, irritability, school and social impact. The child cannot properly concentrate in his or her studies. There is also emotional distress, decreased quality of life. We have seen these pictures earlier. This is a case of atopic dermatitis. It can come as a spot diagnosis in our exam. Now come to the differential diagnosis. What can be the other possibilities? The differential diagnosis include psoriasis, seborrheic dermatitis, contact dermatitis, scabies, ichthyosis, fungal infections, immune deficiencies. But in psoriasis, the key features are sharply demarcated plaques with silvery scales. With silvery scales is the key term. It is not like the atopic dermatitis. In seborrheic dermatitis, it is also common in infants, affects scalp and flexural areas. Here we can see the white rashes. Contact dermatitis related to allergen and irritant exposure. It is the diagnoses are different from atopic dermatitis. So what are the investigations that we should do in case of, if we suspect a case of atopic dermatitis? The clinical diagnosis based on history and examination. We can take skin swabs for if we suspect secondary bacterial infection like Staph aureus. We can do allergy testing, that is IG and skin prick test if we suspect allergen triggered exacerbations, and we can also do patch testing to suspect contact dermatitis, especially in older children. So these are the tests like skin swabs, allergy testing, patch testing we have to do, and we must do complete blood count to look for eosinophils, and we can also do IG. This is written here. Now this is a case of atopic dermatitis affecting the neck of a child. Actually this is an infant. Now come to the management part. So what we can do now for managing this disease? At first, education. Parents and patients need proper skincare guidance and trigger control. We have to control the trigger, we have to control the allergens, we have to take the proper skincare, we have to keep moisture of the skin. Emollients to keep moisture. Apply twice daily and after bathing twice daily, that is BD. Large quantities, 250 to 500 gram per week. We have to use topical steroids, use fingertip unit guide, adjust potency by severity and location. For topical steroid we can use betamethasone, beclomethasone like this, calcineurin inhibitors, tacrolimus for sensitive areas, face, neck. We can also use calcineurin inhibitors. Antihistamines non-sedating for severe itch, evidence is limited. To control the itching we can use antihistamine as a oral tablet. Trigger avoidance, reduce allergens, irritants and infections. And advanced therapies include phototherapy, systemic immunomodulators like cyclosporin, methotrexate. And we can also use biologic therapy, that is interleukin 4R alpha blocker for moderate to severe cases. Subcutaneous injection in every 2 to 4 weeks. The dupilumab is the biologic therapy that we can use. Please try to memorize it because it can come as a MCQ question in mrcp examination. It can come as a MCQ question in mrcp examination. So mark this point. And here is overview of a dupilumab. It blocks IL-4 and IL-13 pathways, reducing type 2 inflammation. It is administered subcutaneously in every 2 to 4 weeks. The common adverse effect, this is the highly high yield question, that is conjunctivitis, common adverse effects, and is reduce pruritus, improve skin, lower steroid dependence. Dupilumab is the medication. And now what about the prognosis? So resolution in case it many improve by adolescence, but some persist into adulthood. Atopic comorbidities like higher risk of asthma and allergic rhinitis. Impact on life, physiological distress due to itch and visible lesions. Early intervention include intervention improves prognosis, reduces infections and complications. And here is a picture of atopic dermatitis. Another picture. The lower extremities is affected. See the excoriation marks. Let's see the excoriation marks here. This is excoriated due to itchiness. Thank you for your active listening. And if you like it, if you like these classes, subscribe Biology to Medicine, that is my channel. Like, share and comment. Thank you.